Hello everyone. Today I'll be covering the topic of typing, grading, and staging of tumors. So, when you get this question, you divide this question into three parts, and I will start with typing. So, what is typing? Now, typing of the tumor is basically when you determine the tissue or the type of tumor. So the type of tissue from which the tumor is arising or the type of tumor. So T for typing, T for the type of tissue, and T for the type of tumor. So that's easy to remember. So if you look here, its definition is that tumors have the histological characteristics of the tissue from which they arise from. So, for example, a squamous cell carcinoma will have stratified squamous cell epithelium, or a urothelial carcinoma of the bladder will have the urothelial cells or the urothelial lining of the urinary system. So, why is typing so important? Because typing helps us select the treatment on the basis of the tumor, and also it helps us in determining the prognosis of a given tumor and where did it arise from. So if you take a look here, a tumor from the epithelial cells is called a carcinoma. So these are malignant cells that form glands and are surrounded by the tumor stroma, which comprises of fibroblasts, collagen, has blood vessels, and inflammatory infiltrate. Whereas the sarcoma is a tumor from a connective tissue. So this was epithelial tissue, but a sarcoma is from a connective tissue, also called as the mesenchymal tumors. And these tumor cells are mixed with the surrounding stroma, and they usually don't have distinct borders. So if you take a look here, you have epithelial tumors which arise from epithelium. So their classification can be according to them being a papilloma, which is usually benign, or a carcinoma, which is malignant. They can also be from the glandular epithelium, which where they can be adenoma, which is benign, or an adenocarcinoma, which is malignant. We also have neuroectodermal tumors, which arise from the neuroectodermal tissue, so tumors of the CNS, which are astrocytoma or glioblastoma, tumors of the peripheral nervous system, including neurofibroma, schwannoma, or nerve sheath tumors, or melanoma, which comes from melanocytes. There are also embryonal tumors which arise from embryonal cells. So there can be germ cell tumors which include teratoma, seminoma, or choriocarcinoma. Or in case of mesenchymal tumors, which are from connective tissue. So wherever you find your connective tissue, your hematopoietic system tumors, leukemias, lymphomas, or soft tissue tumors, fibroma, fibrosarcoma, or maybe uh, from the bones. So you have an osteoma or an osteosarcoma. They can also be there can also be from the adipose tissue, which is a lipoma or a liposarcoma. So again, typing is the type of tissue or the type of tumor. Now, for this one, there is also another thing that you need to keep in mind. So we have the topographical code and the morphological code. The topographical code is basically the anatomical site, and the morphological code is basically the cell type or the histology. So, on the basis of anatomy, we can classify them, or on the basis of the histology. On the basis of histology, we classify them as benign, malignant, or borderline. And according to that, we give them numbers. I don't think the numbers are important. You just need to know that they can be benign, they can be borderline, which is uncertain behavior, or they can behave as both, or they can be in situ lesions, which have severe dysplasia. And the third degree will be malignant tumors. So this is about typing, and this is again a summary of the different kinds of tumors on the basis of the tissues from which they arise. And according to WHO, this classification or the typing of tumor is done by the pathologist, and the pathologist basically assigns an 8-digit numerical code to the tumor, which is not important. You just need to know the number 1 to 3, wherein 1 indicates a benign tumor, 2 is a borderline, and 3 is a malignant. Okay, now the second part of the question, which is grading. So, grading, if we look here, is basically the histologic estimate of the tumor malignancy or assessment of differentiation. Now, what do these complicated definitions mean? So, this means that when we are grading a tumor, we see how does the tumor look like in the tissue where it's growing. Is it similar to, does it look similar to the tissue where it's growing? Or it looks entirely different, or it looks like something totally something else. This is important to determine the correct prognosis of the tumor. So what will the future of a patient who gets such a tumor looks like? And also it tells us about how aggressive the tumor will be. So if we look here at certain examples, now, when we grade a tumor, we classify them by the letter G. So, letter G1 is a tumor that's well differentiated. What do I mean by well differentiated? That such a tumor will resemble the tissue where it's growing. So, if it's an epithelial tumor, then a well differentiated epithelial tumor will look similar to the epithelial tissue. G2 is moderately differentiated, G3 is poorly differentiated, and G4 is undifferentiated. Now, when I say that the tumor is undifferentiated, so again, taking the example of an epithelial tumor, an undifferentiated epithelial tumor is when a tumor is growing in the epithelial tissue, but it looks entirely different. So it has lost like the epithelial looking thing, and it's completely bizarre and it's poorly differentiated and it's entirely something else. So they're bizarre cells. Now, certain examples for this. So over here, you can see the endometrioid adenocarcinoma. And adenoma or adenocarcinoma is basically cancer of the glands. So if I say that the endometrial carcinoma is very well differentiated, that means that there is more than 90% glandular formation within the tumor. So that means it looks very similar to the native tissue. But when I say that it's moderately differentiated, that means there are different and bizarre cells, but the glands are only about 95 to 50%. And when I say that it's poorly differentiated, that means that the tumor has less than 50% of the glands. So this is how you grade the endometrial carcinoma. There are also other examples. So similarly, for a colon adenocarcinoma, you use a similar criteria. And if the patient has G1 or G2 stage, you say that it's a low-grade tumor. And if it's poorly differentiated, it's a high-grade tumor, so the G3 stage. The difference between this is that if the tumor is low-grade, it usually has a better prognosis, but if it's high grade, the prognosis is worse. Here you can see the example of the prostate carcinoma. So a well differentiated one, very nicely made cells. Slowly and steadily, you come to the second stage, which is moderately differentiated, and with the poorly differentiated or the anaplastic one, where there is irregular masses of neoplastic glands, or there is really occasional gland formation. Over here, you have like proper glands forming, more than 95%. But when it's poorly differentiated or anaplastic, there is very occasional gland formation that you see. So these are the examples for grading. Again, grading is to determine the correct prognosis and how aggressive the tumor will be. This grade 1, grade 2, grade 3, grade 4 is basically the Broders classification, and it gives the percentage of anaplastic cells within the tumor. So we have the well-differentiated one, again, the moderately differentiated, poorly differentiated, or the anaplastic or the undifferentiated, which are extremely aggressive and do not resemble the native tissue or the tissue from which they arise from. So grading is usually done microscopically, and of course, we tell the degree of differentiation of the tumor. So this was about grading. Now moving on to the third and the last part of this question, we will talk about staging. Staging is basically for the patient. So you determine the extent of the spread of tumor. So now we're not talking about the properties of the tumor itself, but we're talking about its spread, where it is spreading, where it is going, how it is behaving in the patient's body. And for that, we use the T and M classification system, where T stands for tumor. So over here, we determine the tumor size. If the size cannot be determined, we just say that it's Tx. If there is no tumor at all, we say T0. And then T1, T2, T3, T4 are in the increasing size of the tumor. So, for example, over here, if you see, so T1, the tumor size is less than 2 centimeters. For T2, it's more than 2, but less than 4 centimeters. For T3, you have a tumor which is more than 4 centimeters. And T4 is basically the last stage. So this tumor invades into the bone, the floor of the oral cavity, deep into the skeletal muscles. So this is basically for the squamous cell carcinoma of the tongue or of the oral cavity. Then we move on to the N of the T and M system. N comes from the word nodus, which is for lymph nodes. So again, NX means that it cannot be determined. N0, that means the lymph nodes are not affected. And N1 and N2 depends on on what lymph nodes are affected. And the M in TNM stands for metastasis. So MX means that it cannot be determined. M0 is when there is no metastasis at all. And M1 means that there is metastasis. So again, staging tells us the extent of tumor. There are different systems used, but the most common and the most frequent one is the TNM system or the TNM classification for staging of tumors. And as for certain examples, I would like to use the example of the kidney carcinoma. So if you focus here on this particular picture, with the carcinoma of the kidney or the renal cell carcinoma, if the tumor is less than 7 centimeters in size, so we're focusing just on the T here for now. If the tumor is less than 7 centimeters, we say that it's in stage 1. If it's approximately 7 or slightly or greater than 7 in centimeters in diameter, then we say that it's stage 2. If the tumor has invaded your vena cava through the renal vein, then we say that it's stage 3. And we say that it's stage 4 when this particular tumor has invaded and crossed the Gerota's fascia and also affected the lymph nodes. So that's about the kidney carcinoma. Another example is over here, the FIGO classification of endometrial of carcinoma of the endometrium. The FIGO system is usually used for staging of female genital system carcinomas. And you can see here that we say that it's stage 1 when it is in the endometrium or the myometrium, stage 2 when it is spread to the cervix, stage 3 when there is involvement of the vagina, the cervix, the ovary, and the regional lymph nodes. And stage 4 is when there is distant metastasis or peritoneal metastasis of the endometrial carcinoma. Then there is also the Clark's and Breslow staging. Uh, this staging is used for the staging of malignant melanoma, and you will cover this in the melanoma question. And of course, we have the staging of the esophageal carcinoma. Now, for the staging of esophageal carcinoma, the T1 is just limited to the epithelium and the basement membrane. With T2, it is invading the submucosa and the muscularis layer. With T3, you can see that it has already reached the adventitia. And with T4, it is affecting the blood vessels, it has reached the aorta, it has reached the pleura. If it is affecting the nodes, the regional lymph nodes, then we say that it's N1. And if it is affecting the distant nodes as well, we say that it's N3 or N4. And in case there is presence of a metastasis, we say that it is M1 stage. So again, a short revision. T for tumor indicates the size of the tumor. Tx, not determined. T0, tumor is absent. And T1 to T4 is the increasing size of the tumor. TIS is called carcinoma in situ. N is for nodes. Nodus tells if the regional lymph nodes are involved or not. M is for metastasis. So there is metastasis or the metastasis is absent or it cannot be determined. And finally, when we have performed the TNM classification, we put the tumors into different stages as we discussed for the renal cell carcinoma. So stage 0 is carcinoma in situ without metastasis. Stage 1 is usually small invasive cancer. Stage 2 is a large invasive cancer with nodes involvement. And stage 3 is extensive invasive carcinoma with extensive node involvement. And stage 4 is characterized by distant metastasis of the primary tumor. So this is about the staging with the TNM system. We discussed about the grading of whether it is well differentiated or undifferentiated, and we covered the typing of the tumor, which tells us about the histological type of the tumor, whether it is from an epithelial origin or a connective tissue origin. And yeah, that's about this question. And thank you so much for your attention and see you in the next one.